совсем.
Ну, я же могу подождать чуть-чуть.
Да, вы можете просто поздороваться, спросить, как слышно. Вот даже один человек вас может ответить. Хорошо. Ну все, у вас готово. Если что, я подойду, позвоните или смс напишите, я подойду. Я всегда прослушиваю, смотрю, чтобы все нормально было.
Хорошо. Good day, students. Today, the topic of our lecture is type 1 diabetes mellitus. This disease is characterized by absolute insulin insufficiency due to destruction of beta cells in pancreas. Diabetes mellitus, an autoimmune disease with multifactorial or polygenic type of hereditary. Development of diabetes mellitus depends on genetic and exogenic factors. You may see common genes with their chromosome location. The main one is IDDM1, where location human leukocytes antigen region. A genetic predisposition depends by diabetogenic genes on the short arm of chromosome 6, where location human leukocytes antigen region. If a mother suffers from diabetes mellitus, risk for a child is 3%. If father, 9%. If both parents, the risk for diabetes mellitus is increased up to 30%. Clinical manifestation of diabetes mellitus appears after exogenic or endogenic trigger factors. There are following: beta-cytotropic viruses, enterovirus Coxsackie-B, epidemic parotitis, mumps, rubella, chickenpox, measles, adenoviruses, cytomegalovirus, and other. Toxic factors: nitrosamines, nitrates, vapor. The next exogenic factors, some preparation, beta-adrenomimetics, interferon, corticosteroids, thyroid hormones, growth hormones, nicotinic acid, thiazides diuretics, and other. Nutrition factors: excessive or imbalanced nutrition, excess of animal proteins, excess of purified carbohydrates, taking calf's milk in the first months of child's life. Psycho-emotional or physical stress, secretion of contrainsular hormones, adrenaline, cortisol, glucagon increases, and sometimes maybe season or autumn-winter period when incidence and increase of viral infection increases. Endogenic factors: pancreas disease, pancreatitis, acute or chronic, trauma, neoplasia, cystic fibrosis, congenital defects of pancreas development, aplasia, hypoplasia, ectopia. The next, endocrine disease, thyrotoxicosis, Graves' disease, acromegaly, Cushing's syndrome, aldosteroma, pheochromocytoma, glucagonoma, somatostatinoma. Endogenic factors: pubertal period, the increased production of contra-insular hormones. It will be sex hormones and somatotropin, growth hormone. Now we'll consider the pathogenesis of diabetes mellitus. Pathogenesis includes 6 stages. Now, first stage, genetic predisposition. Symptoms of the disease are absent. Genetic markers of type 1 diabetes mellitus, genes of human leukocytes antigen system of second class, DR3, DR4, sometimes maybe mixed genes. This name ITTM1. Second stage, induction of autoimmune process. Symptoms of the disease are absent. Exogenic or endogenic factors trigger autoimmunity. Third stage, autoimmune insulitis. Symptoms of the disease are absent. Autoantibodies appear. Autoantibodies to beta cells. Autoantibodies to insulin. Autoantibodies to glutamate decarboxylase. And the last one, autoantibodies to tyrosine phosphatase. Next stage, fourth stage, latent form of type 1 diabetes mellitus. This stage, destruction of about 50% of beta cells, insulin secretion decreases, we see a lower level of C-peptide, impaired glucose tolerance at glucose tolerance test, recurrent furunculosis, conjunctivitis, and other disease may appear. Fifth stage, evident form of type 1 diabetes mellitus, residual insulin secretion, destruction of 80 to 90% of beta cells, and manifestation clinical signs of diabetes mellitus: polyuria, polydipsia, hyperglycemia, glucosuria, ketonemia, ketonuria, metabolic acidosis, and other symptoms. And last stage, sixth stage, evident form of diabetes mellitus, when absolute insulin insufficiency, insulin secretion stops, C-peptide is markedly decreased or absent, autoantibodies disappear, diabetes mellitus a severe liability cause, development of late complication of this disease. Now we'll consider classification of diabetes mellitus. First group, type 1 diabetes mellitus, when destruction of pancreas beta cells and absolute insulin insufficiency. There are two variants, autoimmune diabetes mellitus and idiopathic. Second group, type 2 diabetes mellitus, a primary resistance to insulin and a relative insulin insufficiency. Third group, other specific types of diabetes. Genetic defects of beta cells function. There are following: MODY1 chromosome 20, MODY2 chromosome 7, MODY3 chromosome 12, MODY4 and other variant diabetes mellitus. And the last group, gestational diabetes mellitus. Now, clinical signs of diabetes mellitus type 1. Polydipsia, polyuria, weakness, malaise, headache, sleepiness, appetite at onset of disease increased, at progressing ketoacidosis, appetite decreased, at the peak of disease, anorexia. Nausea, coffee ground vomit, pains in the abdomen, at first spastic intermittent pains, round the umbilicus or in the right hypochondrium, later intensive and constant pain, sometimes symptoms of pseudoperitonitis are present, abdominal muscle defense, and Bloomberg signs. Stool in children before 3 years, usually diarrhea. In children over 3 years, constipation. Dehydration, loss of weight, clinical signs of dehydration, skin dry, desquamation, acrocyanosis, sometimes mucotic and purulent infection, hyperemia of cheek, this name rubeosa diabetica, mucous membranes, dry, hyperemic, fissures at the angles of mouth, cracked lips, tongue, scarlet, dry, white coated, later brown coated. Girls may have vulvovaginitis, boy may have balanoposthitis, subcutaneous fatty layer considerable thinnet or disappears, tissue turgor sharply decreased, toxicus mauls respiration because development ketoacidosis, acetone smell from the mouth. The next symptoms: hepatomegaly, heart sounds muffled, tachycardia, because also dehydration, pulse frequent, weak, arterial blood pressure, hypotonia, collapse, sometimes development hypovolemic shock. Common blood analysis, we see leukocytosis, shift to the left, sometimes ESR increased, and metabolic acidosis development. I'd like to attract your attention to this information. Diagnostic criteria of diabetes mellitus, World Health Organization, 1999. Normal glycemia level, fasting, less 5.6 millimole per liter, and 2 hours after glucose load or after meal, glycemia will be less than 7.8. Diabetes mellitus, fasting glucose level more or equal 6.1 millimole per liter in 2 hours after taking food, more or equal 11.1. Disturbance of tolerance to glucose. Fasting glucose level less than 6.1 millimole per liter in 2 hours after glucose load or after meal. Glycemia will be between more or equal 7.8 but less than 11.1 millimole per liter. And the last group, hyperglycemia, it's impaired fasting glycemia level. Fasting glucose level more or equal 5.6 but less than 6.1 millimole per liter in 2 hours after glucose load, less than 7.8. The following information relates to treatment of diabetes mellitus type 1 in children. Basic principles of treatment diabetes mellitus: insulinotherapy, diet number 9, physical exertion, and self-control of glycemia. Basic principles of diet: estimation of carbohydrates is made in grains. Frequent diet regime 5 times a day. to exclude purified carbohydrates, to provide high content of cellulose. Daily calorie content of nutrition equal 1000 plus open bracket 100 times age in years. This calorie divided between proteins, fats and carbohydrates. Protein will be 15 to 20%, fats 25 to 30%, carbohydrates 50 to 60%. Distribution of daily calorie content of nutrition. Breakfast 25%, breakfast 2 10 to 50%, lunch 25 to 30%, tea time 5 to 10%, dinner 20 to 25%, supper 5 to 10%. Grains. What does it mean, grains? 1 grains equal 10 gram carbohydrates. 1 grains equal 40 calorie. 1 grains is 20 gram white bread. 1 grains increases glycemia by 1.7 to 2.8 millimole per liter, and 1 to 2 units of insulin are necessary per 1 grains. Daily amount of grains for children of different age. If age 1 to 3 years, daily amount of grains 10 to 11. 4 to 6 years, daily amount of grains 12 to 13. 7 to 10 years, 15 to 16 grains. 11 to 14 years, for girls 60 to 70 grains, boys 18 to 20 grains. 15 to 18 years, for girls 18 to 20 grains, but boys 19 to 21 grains per day. Now you see different grains. You see half of bananas is 1 grains. 1 apple 90 gram is also 1 grains. And other fruit you see. It's vegetable. We also calculate grains, vegetable and porridge and potatoes and other products. Second basic principles, insulinotherapy. Insulinotherapy basic bolus regime. Physiology. Basal constant secretion of insulin for basal metabolism. bolus or peak secretion of insulin in response to food intake. Basic bolus regime or intensified scheme. Basal level is provided by long-acting insulin in a dose of around 50% of daily dose. Injections 1 to 2 times a day, in the morning and in the evening. Only in the morning or only in the evening. Bolus level is provided by ultra-short-acting insulin in a dose of 50% of daily dose. This insulin we introduction before breakfast, before lunch, before dinner. In treatment of children with diabetes mellitus, we must use only recombinant insulin. Now, classification of insulins. First group, ultra-short-acting insulins. The names this insulin: Apidra, international name insulin glulisine; Novarapid, international name Aspart; and Humalog, international name Lispro. Onset of action: Apidra 5 to 15 minutes, Novarapid 10 to 20 minutes, Humalog up to 50 minutes. Peak action: Apidra 1 to 2 hours, Novarapid 1 to 3 hours, and Humalog 1 hour. Duration of action: Apidra 3 to 4 hours, Novarapid 3 to 5 hours, and Humalog 3 to 4 hours. It's Apidra, it's FlexPen Novarapid, and it's insulin Lispro or Humalog. Second group insulin, short-acting insulins. The name Actrapid and Humulin A. Onset of action: half hour up to 1 hour. Peak action: 1 to 3 hours, and duration of action 6 to 8 hours. And you see it's Actrapid, Novapen 3, and Humulin R. The next group, intermediate acting insulin, Protafan and Humulin NPH. Protafan, onset of action 1 to 2 hours, peak action 4 to 12 hours, and duration of action sometimes maybe up to 24 hours, usually 17 to 22 hours. And the last group, long-acting insulins, Lantus or insulin glargine, Levemir, international name Detemir, and Tresiba, insulin degludec. Onset of action 1 to 2 hours, peak action absent, duration of action, Glargine and Levemir up to 24 hours, but Tresiba prolong up to 48 hours. And you see it's Lantus, it's Flexpen Levemir, and FlexTouch Tresiba. Very rare we used usually for adults person combine insulins Novamix 30. This insulin include Novarapid 30% and Protamine Novarapid 70%. Humulin 3, short-acting insulin also 30%, and insulin Isofan 70%. And last one, Lispromix 25, Humalog 25%, and Protafan Humalog 75%. It's Novamix 30, FlexPen. Now, students, I would like to draw your attention to dose of insulin, an average daily dose of insulin. First year, children necessary 0.5-0.6 unit insulin, daily dose insulin per kg per day. After their development, a honeymoon period or period of remission, 0.1, 0.2 unit per kg per day. Second year, after period remission, again dose insulin increase up to 0.7-0.8 unit per kg per day. Pre-pubertal period 0.6 up to 1 unit per kg per day. Pubertal period 1 to 2 unit per kg per day. And decompensation stage when development ketoacidosis, daily dose on insulin around 1 to 1.5 unit per kg per day. Keep this information in your memory, please. It's a place of introduction insulin subcutaneously. This, for example, a basic bolus regime. We see introduction ultra short-acting insulin before meal, for example, Apidra before breakfast, before lunch, before dinner, and the last injection and at bedtime around 21-22 hours, we introduction only Lantus. Another scheme, before meal Novarapid, and at bedtime Tresiba. And sometimes we do before breakfast 2 injection Novarapid and Levemir. Before lunch, before dinner, only ultra short-acting Novarapid. At bedtime, again, Levemir. This pump therapy, it's a pump Akuchek Comba. And pump Medtronic. Medtronic Paradigm Real-Time Minimed 722. It's a Minimed Paradigm Veo with sensor. And This pump names Omnipod. Omnipod. It's new pump Minimet 640G. It's nano pump. The next principles of treatment diabetes mellitus, physical exertion. Physical exertion increases sensitivity of tissues to insulin and allows to decrease of an insulin dose. Increases rate of glucose absorption by muscles. Increases rate of insulin absorption from the injection sites and normalized catecholamine secretion. Physical exertion should be dosed and regular. Before physical exertion, blood glucose should be within the limits of 6 to 13 millimole per liter. Glycemia over 13 millimole per liter, risk of ketoacidosis. Glycemia below 6 millimole per liter, risk of hypoglycemia. Now you see criteria of glycemic control of type 1 diabetes mellitus. Healthy children, fasting glycemia 3.6 up to 6.1. Glycemia in 2 hours, it's middle level, 4.4 up to 7. Glycemia at night, 3.6 to 6. And glycosylate hemoglobin less than 6. Now, diabetes mellitus compensation, subcompensation, and decompensation stage. Compensation, fasting glycemia 4 to 7, in 2 hours after meal 5 to 11, glycemia at night not less 3.6, and glycosylate hemoglobin less than 7.6. Subcompensation stage. Fasting glycemia 7 to 9. Glycemia in 2 hours after meal 11.1 to 14. Glycemia at night less than 3.6 or more 9. And glycosylate hemoglobin 7.6 to 9. And the last one, decompensation, diabetes mellitus. Fasting level more than 9. Glycemia in 2 hours after meal more than 14. Glycemia at night less than 3 or more than 11. And glycosylate hemoglobin more than 9. Glycosylate hemoglobin, this test is an indicator of blood sugar control during 2 to 3 months. It's glucometers. Now we'll consider late complication diabetes mellitus. There are following: diabetic neuropathy, diabetic nephropathy, retinopathy, diabetic cataract, diabetic chiropathy, fatty hepatosis, lipoid necrobiosis, encephalopathy, myocardial dystrophy, retardation, physical and sexual retardation, sometimes development Mariac and Navicour syndrome. Now we'll consider diabetic neuropathy, polyneuropathy, decrease of tactile, temperature, pain, vibration, sensitivity in extremities. Dull pains in extremities, paresthesias and spasms, decrease of knee reflexes, absence of Achilles reflexes also, dry skin, hyperkeratosis, disturbance of nail growth, and infection complications. Autonomic or vegetative neuropathy, cardiovascular system, arrhythmias, palpitations, change of arterial blood pressure, dizziness, myocardial ischemia, gastrointestinal tract development, nausea, vomiting, diarrhea or constipation, genitourinary tract, hypotonia and dilatation of the urinary bladder. The next complication, diabetic neuropathy, is glomerulosclerosis and chronic renal insufficiency. Stages of diabetic nephropathy. First stage, kidney hyperfunctions, hyperfiltration, glomerular filtration rate more than 140 ml per minute. Kidney hypertrophy and protein level in urine is normal, less than 30 mg per day. Second stage, structural changes in kidneys, thickening of basal membrane, hyperfiltration, glomerular filtration rate also more 140 ml per minute. Protein in urine is normal, less than 30 mg per day. Third stage, onset of diabetic nephropathy. Glomerular filtration rate normal. Microalbuminuria 30 to 300 milligram per day. Arterial hypertension periodic. Fourth stage diabetic nephropathy. Marked diabetic nephropathy. Glomerular filtration rate moderately decreased. Proteinuria more than 100 milligram per day. Arterial hypertension constant. Glomerular sclerosis around 50 to 75%. And the last stage, fifth stage, uremia. Glomerular filtration rate sharply decreased, less than 10 ml per minute. Proteinuria more than 500 milligram per day. Arterial hypertension constant. And total glomerular sclerosis and uremic intoxication. The next complication, diabetic retinopathy, lesion of the retina. Stages of retinopathy. First stage, non-proliferative. Microaneurysms, retina hemorrhage, reduction of visual acuity insignificant. It's a non-proliferative retinopathy. Second stage, pre-proliferative. Multiple hemorrhage, dilatation of capillaries, local thrombosis, formation of shunts, new vessels, reduction of visual acuity significant. It's a second stage pre-proliferative diabetic retinopathy. Third stage proliferative, retinal detachment, vitreous body hemorrhage, loss of vision, or sometimes developed blindness. It's a third stage proliferative diabetic retinopathy. Its treatment, diabetic retinopathy. The next, diabetic cataract. Opacity of the ocular lens due to too long hyperglycemia and formation of sorbitol in the cells. Diabetic chiropathy, affection of intraphalangeal joints of hands. First stage, affection of up to 3 fingers. Second stage, affection of 3 and more fingers. And the third stage, fibrosis of palmar aponeurosis. Lipoid necrobiosis. Skin lesions due to increased glucose content in the skin, microangiopathy and lipoid collagen dystrophy. Diabetic encephalopathy. Attacks of headaches, sensation of pressure in the eyeballs, dizziness, malaise, fatigue, sleepiness, emotional lability, decrease of capacity for work, nystagmus, muscle hypotonia, decrease of abdominal reflexes. Diabetic myocardial dystrophy. Dyspnea or physical exertion. Dyspnea on physical exertion. Palpitation. Heart pain. Dilatation of heart bodies. Tachycardia. Weakening of heart tones. Systolic mumps at the apex and in the Botkin-Erb's point. Fatty hepatosis, fatty infiltration of the liver. Liver accumulation of free fatty acids and lipids in hepatocytes. Liver enlarged, dense, painless. Mariac syndrome. It results from prolonged decompensation, diabetes mellitus, insufficient dose of insulin, or non-following a diet. Clinical signs: retardation of growth, obesity, this obesity as Cushing syndrome, hyperemia of face, xanthochromia of palms and soles, delay of sexual development, menses absent, hepatomegaly, osteoporosis, frequent ketoacidosis, and hypoglycemia states. Navicour syndrome also results from prolonged decompensation stage of diabetes mellitus. Clinical signs as Mariac syndrome, but obesity is absent. We see retardation of growth, delay of sexual development, hepatomegaly, and other symptoms. Students, the lecture is over. Give information about your presence and goodbye. Я решила закончить и не переходить на следующий раздел. Я уже в следующий раз прочту.
Ну, если хотите, можно запустить.
Ну, они уже ушли половину.
32 человека есть.
А было 50 с чем-то, мне кажется, 48.
Ну, можно перенести это, если вы захотите.
Можно запустить, давайте.
Ну, давайте запустим.
Давайте.
Так.
Я хотела сама, потом думаю, наверное, я не смогу.
А я здесь, рядом же здесь.
Ага.
Вот это, да?
Нет, подождите, это русские. Английские комы, я не вижу английских ком.
Может быть, ниже?
Нет,
Нет, это самый низ.
может, выше?
Угу.
Вот английский. Угу.
И небольшую настройку сделаем.
А как вы видите, они ушли, я им сказала, что это закончилось.
Ну, пока еще
Сидят, да?
31 человек.
Угу.
Можно спросить, они напишут. Можно попросить их написать в чат, как слышно.
Угу. Хорошо.
Мне ответят сразу же. Сейчас я дождусь, вот мне появится презентация.
Угу.
Все.
Угу.
Вот задержка 30 секунд. Можете спросить, они вам ответят здесь.
Хорошо. Students, we continue our lecture. Now we will consider acute complication of diabetes mellitus. Acute complication are comas. There are following: diabetic hyperglycemic coma, diabetic ketoacidosis, hyperosmolar non-ketotic coma, lactate coma, and hypoglycemic coma. First, we'll consider diabetic ketoacidosis, hyperglycemic coma. Etiology. A late diagnosis of diabetes mellitus. Inadequate insulin therapy. inadequate insufficiency, usually insufficiency dose of insulin, disturbance of methods and regime of introduction, cessation of insulinotherapy, insulin with the expired term for use, non-observes of rules of insulin storage, improper diet, intercurrent diseases, acute infection diseases, or exacerbation of chronic disease, traumas, physical or mental, surgical interventions, inadequate metabolic control of type 1 diabetes mellitus. Intake of preparations, thiazides diuretics, glucocorticoids, sympathomimetics, cytotoxicosis, Cushing syndrome, pheochromocytoma, and pregnancy. Pathogenesis of diabetic ketoacidosis, absence of insulin in organism, stimulation by glucagon of glycogenolysis, increase of contra-insular hormones concentration. Activation of lipolysis and ketogenesis, intensification of protein catabolism, metabolic acidosis, dehydration due to osmotic diuresis, glucosurias, gamma concentration, electrolyte imbalance, hypokalemia, hyponatremia, maybe development. Clinical characteristics of diabetic ketoacidosis. Vomiting stops, unconsciousness, acetone smell from the mouth, reflexes suppressed, skin dry, cold perioral cyanosis and acrocyanosis, mucous membrane dry, fissures at the angles of the mouth, cracked lips, brown coated tongue, eyeball tone decreased. Muscle tone decreased. Kussmaul respiration, pulse filiform, heart sounds muffled, tachycardia, arterial blood pressure sharply decreased and collapse, GIT system, symptoms of pseudoperitonitis, Bloomberg syndrome, diuresis, oliguria, sometimes maybe anuria, laboratory date, blood glucose more than 20, more than 40 millimole per liter, normal level 3.5 to 5.5. Glucose in urine in normal absent, but ketoacidosis more than 2%. Ketonemia up to 6 to 17 millimole per liter. Normal less than 1.7 millimole. Ketonuria, some classes 3 or 4. In normal absent. Ketonuria absent. Hemoglobin increase. Normal up to 104 gram per liter. Hematocrit also increase. Why increase? Because development dehydration. Normal hematocrit 45-47%. Serum potassium decrease. Normal level 3.5 up to 5.5. Potassium in erythrocytes decrease. Normal level 18 to 100 millimole per liter. Serum sodium decrease. Normal level 135, 145. Sodium in erythrocytes also decrease. Normal level 12 to 25 millimole per liter. Serum osmolarity are normal. 310, 320. pH of blood less than 7.1. pH in normal 7.35, 7.45. Buffer capacity normal up plus or minus 2. In diabetes mellitus ketoacidosis more minus 20. Total blood analysis, leukocytosis, shift to the left and ESR increase. The next, hypoosmolar non-ketotic coma. It is more common in patients with diabetes mellitus type 2 of elderly and senile age. It is 10 times more uncommon than ketoacidosis. Mortality rate exceeds 60%. It develops gradually within 10 to 12 days. Additional fluid losses, vomiting, diarrhea, intestinal infections, acute pancreatitis and other conditions. Fluid deficit in organism. Intake of hyperosmolar solutions, including sweet drinks. Alone intake of preparation, glucocorticoids, beta blockers, mannitol, thiazidase diuretics. Sometimes maybe burn disease, surgery, traumas, hemorrhage, kidney dysfunction. Pathogenesis. Hyperglycemia due to relative insulin insufficiency, unblocking or glyconeogenesis and glycogenolysis. Marked dehydration due to massive glycosuria results from thirst decrease in elderly people. Hyperosmolarity due to hypernatremia, hyperglycemia, hyperchloremia, absence of ketoacidosis, and sometimes appears azotemia. Clinical features of non-ketotic coma. Depression of consciousness, sopor, sometimes maybe coma. Neurological symptoms, cramps, hypothermia, aphasia, dysphagia, paresis, paralysis, nystagmus, meiosis, hemianapsias, hallucination, delirium, meningeal signs, acetone smell absent. Vomiting frequent at the onset disease. Reflexes considerable decreased or absent. Skin marked dryness, decrease of tissue turgor, mucous membranes, considerable dryness, brown coated tongue, eyeball tone, considerable decreased, muscle tone, hypertonia, progressing muscle weakness, respiration, superficial breathing, not Kussmaul respiration, pulse, repeat, weak, soft, hard sounds, arrhythmia, tachycardia, arterial blood pressure decreased, sometimes collapse, sometimes hypovolemic shock. GIT system, pseudoperitonitis is absent because absent ketoacidosis. Diuresis, marked polyuria, is replaced by oliguria and anuria. Blood glucose more than 30, 40. Glucose in urine considerable increase. Ketonemia absent. Ketonuria also absent. and hemoglobin and hematocrit increases, and sometimes microthrombosis development. Serum potassium is normal. Potassium in erythrocytes is normal. Serum sodium more than 150. Serum in erythrocytes also increase. Serum chloride levels increased. Serum osmolarity also increased. 340, 390 milliosmol per liter. pH is normal. Buffy capacity is normal. Blood urea over 7.5. Blood urea normal 4.2, 7.5. Lactate coma. Etiology. Chronic hypoxia, first of all. Chronic hypoxia may be cardiac insufficiency, respiratory insufficiency, anemia, shock, hemorrhage, excessive physical exertion, decrease of lactate clearance, hepatic insufficiency, liver insufficiency, and renal failure. Acute infection disease with hypoxia, increased lactate formation at poisoning with methyl alcohol, salicylates, and other drugs. Pathogenesis. Anaerobic glycolysis increases. The formation of pyruvic and lactate acids increases. Hypoxia slows down the process of transforming lactate into glycogen and lactic acid into pyruvic 1. Lactic acidosis develops at increase of lactic acid level in blood over 4 millimole per liter. The motility rate exceeds 90% and more. Clinical features of lactate coma. Consciousness quickly disappears. Reflexes inhibits. Muscle tone decreased. Acetone smell absent. Dehydration moderate or absent. Skin dry. Turgor is decreased. Mucous membranes dry. Kussmaul respiration more expressed than at ketoacidosis. Pulse repeat. Heart sounds tachycardia is replaced by bradycardia and arrhythmias. Arterial blood pressure sharply decreased. and collapse and shock. GIT, symptoms of pseudoperitonitis, diuresis, oliguria, and anuria. Now, laboratory date. Blood glucose around 12, around 20 millimole per liter, not high. Glucose in urine increase moderately. Ketonemia is not over 1.7. Ketonuria sometimes may be present, maybe absent. Lactic acid more by 5 to 10 times. Blood urea increased. Serum potassium increased. Serum sodium normal. Serum osmolarity normal. pH 7.2 up to 6.8. Buffy capacity -10 and lower. Principles of treatment: diabetic ketoacidosis. Okay, students, this part lecture we'll consider the next time. Now our lecture is over. Алло, Дима, ну все, вот я на 10 минут раньше закончила с учетом отсутствия перерыва. Угу. Я подумала, что я без перерыва. Короче, на лечение не закончила.
Тогда завершаем трансляцию.